इसे फुल कर दो. Salam and hello everyone. There's Dr. Mazam, and I'm filling in for Dr. Sohaib today. And the topic for today is very important, and it's about urine analysis. Okay, first of all, I hope you all are doing fine. Can you all hear me? Okay, good. Okay, so first of all, urine, as you all must be knowing by now, it's basically complex fluid, 95% water and 5% solids, and it's the end product of metabolism by a variety of cells in humans as well as in animals. And the urine flows from kidneys through the ureters to the urinary bladder, and from there the urine goes out through the urethra. And it's formed by kidneys round the clock. Waste products are basically made during metabolic process, and that they're excreted in the urine. Does anyone have any idea what the average urine output is per day? The average output of urine per day. Can you guys hear the question? Do you have any idea? Okay, anyway, it's 1 to 1.5 liters, and some places mention that it's 2.5 liters, or like 4 to 6 cups per day. Okay, okay, basically, urine analysis is a very important routine test that is prescribed. And it's important to state that urine analysis is the second most common test that is prescribed by physicians, which you all would be prescribing as physicians as well. And it's the second most common routine lab test that is performed. Does anyone know what's the most common one? Very good. Yes. Sidra has answered CBC, Javeria, Ayman Tariq, Faza Asif, Yaskul Father. Yes, CBC is the correct answer. Yes. That is the test which is prescribed the most, and it's the uh, most common routine lab test that is performed. Okay. Now we will talk about how this urine analysis is done, and there are various methods for that. Okay. So basically, the urine is collected in a wide mouth container from patients, and the ideal way of collecting the specimen is via midstream. And you all must be knowing what midstream is, right? It's basically while the person is urinating, the person doesn't collect the sample immediately. The person lets the urine pass, and then in the middle of it, collects the sample of urine. Does anyone know the reason behind this? Why a midstream specimen is the most ideal for processing? Any idea? Okay, so the main reason why midstream urine is so ideal is because it avoids contamination by normal flora of the genitalia, and the common normal flora of the genitalia is, which you must know, is Staphylococcus epidermidis, and in females it's lactobacilli. Okay. Now, as for the types of urine sampling, there is random specimen, for which there is no specific time, and it's the most common one, and it's taken any time of the day. And the purpose for this is routine screening for checking the chemical components, and FEME, which means full examination and microscopic examination. So, like, it is completely examined with all its components. We'll come to that in the different types of examinations that are done of the urine. Morning sample. There's basically the first urine in the morning, and it's the most concentrated urine. And it's mainly used for pregnancy tests and microscopic tests to check the microscopic components in the urine, those that cannot be seen by the naked eye, like maybe the presence of white blood cells, pus cells, RBCs, etc. Okay, third one is the midstream, which we were talking about. It's called clean catch because uh, it avoids contamination by normal flora that's there. Okay, and it also mentions what I was stating earlier, that first few milliliters is discarded, and then the rest of the urine is collected. And the purpose for that is culture, to check whether there's any bacteria or any microorganism in the urine. Then the other type is 24 hours, in which all the urine passed during the day and night, and the next day the sample is collected for that, and it's used for quantitative and qualitative analysis of substances. Postprandial, and it's done 2 hours after meal. It's to determine glucose levels in diabetic monitoring. And then the last one that's mentioned here is suprapubic aspired. And this, the needle is put in the area where the urinary bladder is, and its purpose is to obtain sterile urine. So, and this suprapubic aspired collection is done in mainly those patients who are comatose or are bedridden, they cannot move. So if you have to collect the urine sample, you have to inject the needle in the suprapubic region where the urinary bladder is to collect the urine. Yes. 24 hours. Okay, it's when asked that what's the difference between 24 hours and morning sample. In morning sample, you just, it's not like you've been collecting all that's been there for 24 hours just like that. For 24 hours, you have to constantly keep collecting the urine. Like the urine that's been, like those patients you must have seen in the wards who have this bag around them where the urine is collected. So people monitor that for 24 hours. That's a separate thing. Morning sample is like anyone who's not admitted or something. Maybe people are suspecting pregnancy, for example. So there was no previous sample collection, just randomly in the morning, the urine is collected. That's it. Okay. Next, we move on to the preservation of the urine. Important thing to note in this is that uh, normally urine is analyzed within 2 hours. Okay, the reason for that is that because if you delay, it might get contaminated by other bacteria and other substances. Other things can cause contamination, so it's good to analyze it immediately. So within 2 hours, it is analyzed. But if there is an emergency and one needs to preserve it for a long time, like for 24 hours, then the following preservatives are used, which you can see on the screen here. Hydrochloric acid. This is used when detecting adrenaline, noradrenaline, vanillyl mandelic acid, and steroids. Toluene is another preservative. It forms a thin layer, and so as a result, it forms a physical barrier against bacteria and air. Okay. And third one is boric acid. This is very important because if they ask you which preservative is used the most for urine samples, the answer to that is boric acid. And even here at Dow Lab, this is the preservative which is used, boric acid. General preservative. Sample can be kept for 2 hours even without refrigeration. Thymol inhibits bacteria and fungi, and formalin excellent for preservation of formed elements. Okay, next we come to the various components of urine examination. So in urine analysis, it's basically examination of urine for medical diagnosis. It consists of the following components. We'll explain what they all mean, but basically they are physical examination, chemical examination, and microscopic examination. Uh, what do you understand, just to get an idea, whether you guys know this already or not, what do you think physical examination is? Very good, very good. This has been answered by Sidra Musa. The naked eye exam, yes. What's apparent to the naked eye? Aman Tariq is saying color, yes. Very good. Color output, yes. Zainullah is mentioning color, yes. Color of the urine, the way it looks. By Arisha Nawaz, yes, that's correct. Its color. Density, well, one cannot tell exactly by the eye, but okay, it would come in like, yeah, one can say. Appearance, color, what else can you perceive like when you see urine? What else? There is the sight, there is what? We'll come, okay. Uh, some people have mentioned pH and specific gravity. We'll come to that. It's not in physical, but yes, it is an important part of examination. Yes, smell, odor, yes, particular smell. That's been answered by Ramisha, Anas Hashim, Sidra Musa, Ghania Khan, Muhammad Shamil Khan. Yes, very good. Presence of gross hematuria has been mentioned by one. Okay, that comes in appearance. Concentrated or dilute. Okay, yes. Okay, so most of the people have an idea, but we'll mention all of this in detail. Okay, a urine examination. Okay, next one. Okay, yes. Macroscopic urine analysis. Macroscopic, yes, as you all would know, one thing is microscopic, which you cannot see. Macroscopic is what's obvious. It is the direct visual observation of the urine, noting its volume, color, clarity, or cloudiness, etc. Normal urine is typically pale yellow and clear. Obvious abnormalities in the color, clarity, and cloudiness may suggest different diseases. Okay, so there's the normal appearance, as you can see on your screens. There's what normal urine looks like. Okay, so now on this slide, on one side we have normal urine and its various components with all its different percentages that's mentioned there. No need to read out all of this. And like I mentioned earlier, urine is 95% water and the rest of the components are solid. Okay, on the other side, you can see abnormal urine. So, for example, if the urine color is let's say pale to colorless, like almost water-like color. Pale to colorless. It could be because of large fluid intake, diabetes. If it's dark yellow or brownish red, it could be due to dehydration. Clear red could be hemoglobinuria due to intravascular hemolysis. And cloudy red, hematuria, as one person had mentioned earlier. Okay, another important thing is food and medication. Food and medication can also have an effect on the color of the urine. For example, urine that's colored like beets, like beetroot. Okay, that could be due to vitamin B12. Okay, bright yellow color. Yes, it also comes in that vitamin B12. It can cause that. Okay, another important point. Remember, and it's an often repeated BCQ as well. Among the drugs that are taken for TB, there is one particular drug that causes the urine color to be reddish orange. Can anyone recall that? Very good. Yeah, most of the people, yeah, they're answering immediately. Rifampicin. I can't even mention all the names right now. The list is just appearing. Okay, yes, rifampicin. And a very funny way to remember it is that the slang word for urine is piss, right? So rifampicin. So that's how you can remember it. Very good. Okay. Just like that, sulfonamides can result in rusty yellow or brownish urine, cloudy urine, like it can be because of pus, blood, WBCs, and can be seen in UTI. Cloudy urine can be seen in urinary tract infection and schistosomiasis. Okay, let's move on to the next slide. Okay, physical examination continued. Odor. Okay, like we mentioned first, there was the color, then there's the odor. Normal odor is aromatic due to the volatile fatty acids. On long-standing ammoniacal decomposition of urea forming ammonia, which gives a strong ammoniacal smell. Okay, foul offensive smell could be due to pus or inflammation. Sweet, sweetish smell, like that it could be in diabetes. Fruity smell could be in ketone urea. Maple syrup like, as it's obvious from the name as well, it's seen in maple syrup urine disease. And rancid, like rotten, it's seen in tyrosinemia. And like basically all these obvious things, they give you an idea as well of what could be wrong. Like if you're seeing that the color is different, the odor seems different, so you can make differential diagnosis. And with further examination, you can even reach the exact diagnosis as well. Okay, as for the normal volume, I would have asked questions like, do you have any idea about what the normal volume is and these different definitions, but it might take some time. But uh, okay, we'll just go with this. We can see it's obvious on this slide as well. The normal volume is 1 to 2.5 liters per day. As I was even asking earlier, when I was asking, does anyone of you have an idea how much urine output is per day? So normal is 1, some books say 1.5, there's like 1 to 2.5 liters per day. Okay. Oliguria is urine output that is less than 400 ml per day. That's basically decrease. And it's seen in cases of dehydration, shock, glomerulonephritis, renal failure. Polyuria is the opposite of oliguria. It means increased urine output more than 2.5 liters per day. And it's seen in increased water ingestion and diabetes mellitus and insipidus. In diabetes, because of excessive sugar, the patient urinates a lot. And because of that excessive urination, the patient then, to compensate for the loss of the fluid, feels more thirsty. So as a result of it, the patient will take more and more water. So that would result in increased water intake, and that would increase the urine output as well. Anuria, it's basically urine output less than 100 ml per day, and it's seen in renal shutdown. Okay. The other components which are not obvious, like when you look at the urine itself, you have to perform certain chemical tests or examine under a microscope. So we have chemical tests in which we check the pH, the specific gravity, glucose, proteins, ketones, bilirubin, urobilinogen, blood, nitrite, and in microscopic examination, because the things that are mentioned under the heading of microscopic examination, they cannot be seen by the naked eye. So for all of these things, we need microscopic examination. Okay. And we will talk about all these things briefly. Okay, right. Mhm. So, okay, in the different chemical components, these are the different reference ranges that are given for the various components that can be present in the urine. Like for leukocytes, the normal levels are mentioned, and it also mentions that if it's higher than a certain amount, it may indicate UTI. Nitrites are negative, and as you might know, nitrites are made by certain bacteria such as Enterococcus, Pseudomonas, and the most important, this can even be your BCQ, uh, nitrite forming bacteria. Among them, the most prominent is the Proteus one, which causes UTI. Okay, you can even note that down. Okay, urobilirubin, its normal value is given more than the normal. It may indicate liver issues. Protein, among the topics for today, is proteinuria, so we'll come to that. pH optimal is 7 to 7.5. Okay. Uh, we'll deal with all of these in the next slide. Blood, there should be no blood. There should be no blood at all in the urine, but trace may indicate several issues. There are, many differential diagnoses. Specific gravity, we'll also talk about this. Ketones, presence of ketones may indicate fat metabolysis or diabetes. Bilirubin is also negative. Trace or more indicates liver and or gallbladder issues. And glucose is it's very well known that it can indicate diabetes. Okay, and certain drugs may increase bilirubin. It's written under this chart. Certain drugs can also have effect on the different types of components that are seen in the urine. Okay, so basically chemical examination of urine analysis. It is used to detect glucose, protein, all these components that we mentioned in the chart that you just saw. Okay, a very important uh, way of doing chemical analysis is via the dipstick. Now, what is the urine dipstick? It is a narrow plastic strip which has several squares of different colors attached to it. Okay, and all of these small squares, right? They have different chemicals in them which react to different types of components that can be present in the urine. So, like, there is a small square that uh, might detect glucose component in the urine. The other square might detect bilirubin. Another one might detect ketones, right? So it's like that. Colors generated by each pad are visually compared against a range of colors on brand specific color charts, as you can see over here. Like on this slide, you can see the strip is being compared, right? So the entire strip is dipped in the urine sample, and color changes in each square are noted. So, like we were mentioning earlier, glucose would show diabetes, bilirubin might indicate liver disease or RBC breakdown, ketones are suggestive of diabetes, and even fasting or starvation for a long time. Specific gravity. Now, do you all know what specific gravity is? Anyone? No. One could say a measure of density. Yes, it's basically like the amount of solutes that are present in the urine, ability of the kidney to concentrate urine solutes. Yes, yes. Muhammad Shamil Khan has said solutes to volume. Yes. Ramesh says density. Yes. Measure weight of dissolved particles in the urine is a very good answer given by Aroma Shaukat. Okay, and ratio of gravity of that substance to that of water. Yes, Citramos has given a very good answer. Ratio of gravity of that substance to that of water. And yes, so basically it's the ability of the kidney to concentrate urine solutes in the urine, and its weight of urine compared with distilled water. And do you know what the normal specific gravity is? Yes, for water it's 1, and for urine, the specific gravity for urine. Okay, there is an answer 1.002 to 1.03 given by Javeria. Yes, that's correct. And Aroma Shaukat has mentioned 1.001. That's also correct. So yes, variations have been mentioned in books. So just to sum it all up, regarding the specific gravity, the normal specific gravity is it ranges from 1.003 to 1.035, and in concentrated urine it's 1.025 to 1.030, and in dilute urine it's 1.001 to 1.010, and these values are all given in your books. It's not necessary you have to note it down even right now. You can just check what the normal specific gravity is, and you will find the values in your books. And okay, and so there are certain conditions in which the specific gravity is increased. Uh, they would be increased in what kind of condition? Like dehydration, for example. Specific gravity would be increased in dehydration, in diarrhea, in vomiting, where excessive fluid is lost, and that results in increased specific gravity. And as for decreased specific gravity, it's due to renal failure, diabetes insipidus, because there is too much fluid in when the diabetic patient is taking too much water. So not many solutes are seen in that, so that would decrease the specific gravity. Excessive fluid intake would result in decreased specific gravity, and you guys can even make a chart on all these things, right? Like for example, if you want to specifically deal with the topic of specific gravity, you can make separate charts for those things that increase specific gravity, and those things are decreased. Okay, now coming to the other components, blood that is seen in the urine that could indicate stones in kidney or the bladder, hemolysis. pH, as you all might know, urine is slightly acidic. It's 6 to 7.5. pH less than 7 would indicate acidosis, as seen as it's also seen in uncontrolled diabetes. And in case of alkalosis, the pH would be higher. Okay, and protein component, we will deal with this in when we talk about proteinuria. And urobilinogen indicates liver disease. Nitrite, as we mentioned earlier, it indicates presence of bacteria. And leukocyte esterase. Leukocyte esterase, it's basically inside the WBCs. So, of course, in cases of infection, we will see more WBCs, right? So that would result in more leukocyte esterase as well. Okay, now we come to the microscopic analysis. In microscopic examination, as we mentioned earlier, there are certain components of the urine which cannot be seen by the naked eye, right? So for that, we need a microscope. It is used to view elements that are not visible. And the method for that is basically that sample of urine is centrifuged, and the sediment is like the part that goes under, right? No need to explain that. I'll show you in the diagram. Sample of urine is centrifuged and the sediment is examined on a slide under a cover slip with the microscope. It's like this. The part that settles down, this is the sediment that's taken after centrifugation, and you put it on the slide that is checked under a microscope. So what are the microscopic things that can be seen, like, while performing the microscopic urine analysis? Feza Asif has replied RBC, WB. Yes, Sidram also WBC, RBC. People are answering. Yes, RBCs, WBCs casts. That has been written by Javeria. Epithelial. So yeah, all these things can be seen under a microscope. These are the things that are not visible to the naked eye, right? Okay, so coming to RBCs, hematuria is the presence of abnormal numbers of red cells in the urine. It could be due to glomerular damage, tumors, urinary tract stones, upper and lower urinary tract infections. And hematuria is of two types. One is gross hematuria. It means that the blood can be seen by the naked eye. The urine may look pinkish, brownish, or bright red. And then there is the microscopic hematuria, which means that the urine is clear. Apparently it seems clear, but blood cells can be seen under a microscope. So like, see, on the topmost thing, you can see gross hematuria. The blood is very obvious in this. And the other sample has microscopic hematuria, for which we require a microscope. Red blood cells can indicate different things. There are different differential diagnosis for this. Some of the things that are mentioned are renal diseases like glomerulonephritis, schistosoma hematobium, which is basically a urinary blood fluke, and it's a parasitic infection. And physiological changes can also result in RBCs seen in the urine. Okay, RBCs may stick together and form, just like some people were mentioning, casts are the things that are seen. under a microscope. So some red blood cells may stick together and form red blood cell casts. Such casts are indicative of glomerulonephritis, with leakage of RBCs from glomeruli. White blood cell casts can also be present with glomerulonephritis, and their presence indicates inflammation of the kidney, because such casts will not form except in the kidney in the case of white blood cells. There's the diagram which shows what these erythrocytes look like under a microscope. So just like RBCs, white blood cells were also mentioned by a lot of students. Yes, these can also be seen under a microscope, and this called the specific term for this is pyuria. So white blood cells or even pus cells, the term is pyuria. Pyuria refers to the presence of abnormal numbers of leukocytes that may appear with infection in either the upper or lower urinary tract or with acute glomerulonephritis. And the normal range is given over here, that the WBCs, they should be less than or equal to 2 to 5 per. What does HPF stand for? High power field, which means the maximum magnification that's used to check the things under the microscope. So more than this, if it's seen, then that indicates infection. This is what WBC looks like under microscope. These are the casts that are seen. Epithelial cells were also mentioned by students. Yes, renal tubular epithelial cells contain a large round or oval nucleus and normally slough into the urine in small numbers. However, with nephrotic syndrome, and this is an important point, and in conditions leading to tubular degeneration, the number sloughed is increased. The normal number that's usually there of epithelial cells, it's like less than or equal to 15 to 20 squamous epithelial cells per high power field. More than this would indicate the things that are mentioned on this slide, like nephrotic syndrome, tubular degeneration. Right. There's what epithelial cells look like under a microscope. Casts. This was also mentioned by the students. Urinary casts are cylindrical structures produced by the kidney, and they are present in the urine in certain disease states. They are formed in the distal convoluted tubule and collecting ducts of nephrons. Then they dislodge and pass into the urine, where they can be detected by microscope. And urinary casts may be made up of cells like, as we mentioned earlier, WBCs, RBCs, kidney cells, or substances such as protein. And these casts, how are they formed? They are formed by precipitation of tam horsefall. It's a type of protein, mucoprotein, which is secreted by renal tubule cells, and sometimes also by albumin in conditions of proteinuria. Cast formation is pronounced in environments favoring protein degeneration and precipitation, such as low flow, concentrated salts, and low pH. This is what all these look like under a microscope. Okay, other findings can include yeast cells, and they can be differentiated from red cells because of their oval shape. And some of the yeasts usually show single budding, and they indicate fecal contamination, vaginal candidiasis, or diabetes due to high content of glycogen. Another important thing is crystals. Crystals, some of Some crystals are normally seen in the urine, whereas other type of crystals can indicate certain complications or problems. So crystals can be seen in certain clinical scenarios such as kidney stone disease or acute crystal nephropathy. Okay, and in this diagram you can see some of the normal crystals and some of the abnormal crystals. Like cysteine is not supposed to be present at all. It would indicate cystinuria. And tyrosine crystal would indicate tyrosinemia. Acyclovir could be because of taking acyclovir meds. And just to recall that acyclovir is taken by patients of herpes and chickenpox, like that. So it could be also because of medication, because maybe someone's taking certain medication that could result in certain types of crystals being formed in the urine. Okay, we're done with basically the urine analysis. The next part of this lecture was proteinuria. So just a brief introduction for proteinuria is that basically kidneys, as you all know, they are filters that do not allow a lot of protein to pass through. And if there is a lot of protein in the urine, that would indicate damage to the kidneys. And what would cause someone to suspect that they have proteinuria? Like, because when someone urinates, they will not be like, there's a lot of protein or something. There must be something that would raise suspicion. So things that raise suspicion are foamy urine. Like, because of excessive protein, the urine could be foamy, and there could be excessive urination along with fatigue as well as cramps, muscular cramps. Okay. Now, coming to the definition of it, proteinuria is basically the presence of abnormal quantities of protein in the urine, which may indicate damage to the kidneys, as I mentioned earlier. Normal urinary protein excretion is this much. It's less than 150 milligrams in 24 hours. And of that, the different components are given of the urinary protein. Tam horseful protein secreted, that's 40%. 40% of it is low molecular weight immunoglobulins such as urokinase, peptide hormones, and 20% of the urinary protein is albumin, and normal albumin excretion is less than 30 milligrams in 24 hours. Okay, normal urinary protein excretion is less than 150 milligram in 24 hours, as mentioned in the previous slide as well. And an important thing to note is that abnormal levels of protein can give you a lot of clue and idea on what the problem could be. For example, in nephrotic syndrome, the range of proteinuria is defined as greater than 3.5 grams of protein excreted in the urine over 24 hours. And here, as you recall from the chemical test, remember there was this urine dipstick that was used to check the various chemical components of the urine. We mentioned earlier, like blood, bilirubin, nitrites, ketones, etc. And when I mentioned protein earlier, I said that when we would be talking about proteinuria, then I'll mention it. So, okay, just like that, uh, protein component of the urine is also checked, and there are the different values and ranges that are given, which indicate what what the severity of proteinuria could be. So these are the different ranges that are given. And as far as mechanism of proteinuria is concerned, then it's affected due to either glomerular injury, for example, which results in abnormal losses of intermediate molecular weight proteins like albumin, and tubular damage. It results in increased loss of low molecular weight proteins. Low molecular weight proteins would be like lysozymes, amylase, polypeptide hormones, insulin, growth hormone, etc. Okay, a specific type of proteinuria is albuminuria, like excessive amount of albumin being excreted. Albuminuria is a pathological condition wherein the protein albumin is abnormally present in the urine. And as you all know, it's a major plasma protein. In healthy people, only trace amounts of it are present in the urine, whereas larger amounts occur in the urine of patients with kidney disease. Normal excretion rate of albumin is 5 to 10 milligrams per day, with an albumin excretion rate of more than 30 mg. If it's more than 30 milligrams per day, then it is considered abnormal. And another important point to note is that more than 300 milligram per day shows severe albuminuria. And another important thing, you can note this down as well. It's very important to know this as well, that albuminuria, which lasts for 3 months, like if it continues for 3 months, then it is termed as chronic kidney disease. You can suspect chronic kidney disease in that. More than 300 milligrams albumin per day that's excreted out can indicate chronic kidney disease. Okay, so basically, what are the causes of proteinuria? That could be anything that results in damage of the kidneys. It can be seen in diabetes, high blood pressure, in lupus, glomerulonephritis, kidney inflammation, multiple myeloma, preeclampsia, which affects pregnant women, and that the blood pressure is also highly raised, amyloidosis, abnormal accumulation of protein, cardiovascular diseases, intravascular hemolysis, to name a few. So basically, anything that can result in severe kidney damage can result in proteinuria. And further, it's categorized into different types. There can be glomerular proteinuria, which mainly results in the loss of albumin, tubular proteinuria, low metal poisoning. Okay, overload proteinuria is also very important. Abnormal type of proteins are also seen in the urine. Postrenal proteinuria, these are protein below kidney, and this can be seen in conditions like inflammation, bleeding, and malignancy. Okay, in this overload proteinuria that you see on number 3, we will mention two important ones in this, two important types of proteins that are seen, and a lot of BCQs also come related to this. And you will notice that these are like giveaways for certain diagnoses as well. So, okay, coming to this, Benz-Jones proteins. These are not to be seen in the urine. These are abnormal proteins they're small in the urine. Testing for these proteins is done to diagnose and monitor, especially multiple myeloma and other similar diseases like Waldenström, macroglobulinemia, and plasmacytoma. Benz-Jones proteins are basically a tumor marker. You all know what tumor markers are? Tumor markers are serious red flags, but I'm just giving you time to send answers. Okay, tumor marker is basically a red flag. Like these are basically certain substances which if they are produced by the body, they can indicate a certain type of malignancy. Yes. One answer has been written by Hadiqa Talha. Yes, these indicate the severity of tumor progression. Yes, that's correct. They indicate tumor progression or malignancy. So just like that, Benz-Jones proteins, they are tumor markers for especially multiple myeloma. There are other diseases as well, but the most important one is multiple myeloma. And there's what they look like. Okay. And in multiple myeloma, basically it's the cancer of the plasma cells. The importance of plasma cells is that they produce the antibodies that are needed to fight off infections. So, abnormality, malignancy in these plasma cells can result in serious complications and infections, and it's a very fatal disease. Similarly, another thing is beta 2 microglobulin. It is found on the surface of almost all cells in the body and is shed by cells into the blood, particularly by the B lymphocytes that make the plasma that differentiate into plasma cells and tumor cells. Beta 2 microglobulin is not an abnormal finding, but it can indicate, like certain conditions if there is an already existing problem. So it's present in most body fluids and its level rises with conditions that increase cell production and or destruction or even conditions that activate the immune system. So increased levels of beta 2 microglobulin in the blood and or urine indicate that there is a problem, but they are not diagnostic of a specific disease or condition. Okay, like as I mentioned earlier, in multiple myeloma, Benz-Jones proteins are the main finding. But like suppose if a patient of multiple myeloma is getting treatment and you're seeing that there is not much effect on the Benz-Jones proteins and there is also an increase of beta 2 microglobulin, that shows that the treatment is not having much effect. As But if there is some effect of the treatment, you will see some decrease in the levels of beta 2 microglobulin. So it doesn't indicate anything specific, but it does show the prognosis, or it helps you figure out how the treatment is going of certain diseases. Okay, a very important point to note. I think this you should note down or take a picture of this. Beta 2 microglobulin, the important thing is that it differentiates between glomerular and tubular dysfunction. In glomerular diseases, now there's the thing, beta 2 microglobulin increases in the serum, but it decreases in the urine. And in tubular dysfunction, beta 2 microglobulin decreases in the serum and increases in the urine. If you remember, uh, for example, if you want to memorize this, if some people want to memorize it like this, they can know what happens in, for example, glomerular disease, and the opposite would be true for tubular dysfunction. So if one wants to ask, in case of beta 2 microglobulin, how will you find out whether it's due to a glomerular disease or due to tubular dysfunction? Then you can figure out where the problem lies. Okay, normal levels for this, it's good to know the normal levels as well. In the urine, in 24-hour sample, it's less than 1 milligram in 24 hours. I've noted down some of the causes that result in increased urinary levels: drug toxicity, lymphoid malignancies, chronic renal infection, AIDS, Wilson's disease, and renal tubular damage. and the normal levels in the serum is less than 2.7 milligram per ml. Increased levels are seen in renal dialysis, multiple myeloma, viral infections, amyloidosis, glomerular diseases. Okay, yes, so these are the main things you need to know for this topic. And okay, we're done with this topic. And a very important book which I wanted to mention was this one, Clinical Pathology Interpretations. There's a very good book uh, which can be very useful for you in the wards and in the labs as well. And this particular chapter on urine analysis is given very well in this particular book, Clinical Pathology Interpretations. The most recent edition is the fourth edition that has come out. It's from 2019. So, hope you all had a good time. It was. I hope this wasn't boring at all. I hope you guys would derive some benefit from this class, and wish you all very well. Okay, someone. Okay, okay, why beta 2 microglobulin has got this mechanism like in glomerular disease that increases in serum? Basically, it's the result of the different findings that people have took, like through constant research work, through clinical research. It has been noticed that if the level of this microglobulin is increased in the urine, then it indicates this sort of problem. If it's more in the serum, it indicates this. So that's how it's known. So that's okay. So that's about it. And wish you all the very best. Take good care of yourselves.